สวัสดีค่ะ Hello everyone. My name is Sirimon Reutrakul. I am an endocrinologist and currently a professor of medicine at the University of Illinois at Chicago in United States. I am also a visiting scholar at Ramathibodi Hospital in Bangkok, Thailand. Today, I'm delighted to be talking to you and sharing our experience in teaching patients with type 1 diabetes to count carbohydrates in Thailand. I would like to thank Action for Diabetes for inviting me and giving me this opportunity to share our experience. We basically start this from zero, roughly in 2013. A quick background on type 1 diabetes. This is a position statement from the American Diabetes Association, which says that most individuals with type 1 diabetes should be treated with multiple daily insulin injections, 3 or more injections per day of prandial insulin, and 1 to 2 injections of basal insulin or using insulin pump. They also should be taught in how to match prandial insulin dose to carbohydrate intake, pre-meal glucose, and anticipated activity, and that most individuals should use insulin analogs to reduce hypoglycemia risk. And this profile shows you glucose levels on the bottom graph from a non-diabetic individual that had glucose levels measured throughout the day. And you can see that it rises after breakfast, lunch, and dinner. Simultaneously, the insulin levels was measured in the top graph and goes along as a mirror image with the glucose levels. There is no one insulin that can be injected and produce the top graph right here, which is something that people with type 1 diabetes would like to have as far as their insulin level. So they use a combination of a basal insulin here shown in purple line that is peakless, and at each meal they would use prandial insulin depending upon the blood sugar and the carbohydrates intake. This is easier said than done, and this is the point of this talk in sharing how to teach them to do these little green curves. For meta-analysis, carbohydrate counting was shown to be effective in lowering hemoglobin A1C of about 0.6%. So we like for people to match the insulin with carbohydrates that they take in, rather than matching carbohydrate with the insulin that we order. And that is to give them more flexibility in the food that they like to consume and hopefully more quality of life. So for a general principle of carb counting, we know that we like to have people count in portions or in grams. We use 1 carb equals to 15 grams of carbohydrates. And if different program may use differently, I believe Daphne uses 10 grams for 1 exchange. However, it's important to tell the patient that this is not the weight of the food, but is the carbohydrate contents in that meal. We use the methods of best estimation, including counting all hidden sugars, gravy, crust, etc. And errors can be acceptable up to about 0.5 to 1 carbs, so 7 to 15 grams, depending upon the insulin sensitivity of that individual. We teach the patient that 6 food groups that contain carbs are the obvious starches and root vegetables like rice, noodles, potato, yams, and a lot of these are staple food in Southeast Asian countries. Fruits, starchy vegetables, including the ones that you generally have to chew, for example, broccoli, Chinese broccoli stems, carrots, peas, cauliflower, etc. Milk of all type, regardless of the fat content, and this is something that the patients do not understand. If they eat non-fat milk, that contains sugar. Sweets, obviously, and sugar and syrup and sweetened beverages. These last 2 items we like them to consume at the minimum amount. General principle about insulin in type 1 diabetes, more like remarked. For basal insulin, if you use glargine or detamere, people know that this may need a twice a day injection. If you use a newer analogs that have longer half-life, once a day is sufficient. When people need twice a day, you might notice that the blood sugars are elevated before the next injection and actually may be low 8 to 12 hours after the injection because the glargine and deramine sometimes produce small peaks. The total daily insulin dose is the key factor that would determine that person's insulin sensitivity. If they require less than 30 units per day, they're relatively insulin sensitive. As a result, sometimes 1 unit of insulin is too much, and half a unit insulin may be needed. And in our area, there's an insulin pen that can deliver the dose in a half units increment. If someone requires more than 1 unit per kilo per day, you might need to be looking for possible problems. For bolus insulin, we are talking about insulin analog that we use at mealtime. And there are 2 factors that are essential in determining bolus insulin. First of all, the insulin to carb ratio. This would be the insulin amount that they would need for the food that they're about to consume. The insulin to carb ratio is determined by taking a number of 500 or 450 divided by total daily dose. For example, if the person takes 12 units of glargine and a day aspart 6 units 3 times a day, total daily dose is 30. The insulin to carb ratio or ICR would be 450 divided by 30, which is total daily dose, equals to 15, which means that 1 unit of rapid insulin analog would cover 15 grams of carbohydrate. For insulin sensitivity or correction factor, this would be 1700 or 1800 divided by total daily dose. For example, if the same person with a total daily dose of 30 units per day, the insulin sensitivity would be 1700 divided by 30 equals to 56, meaning that 1 unit of rapid acting insulin analog would lower the glucose in that person of 56 milligrams per deciliter. So to summarize again, the bolus insulin has 2 components. First is insulin for planned carb intake, which is determined through insulin to carb ratio. Second is the correction insulin for high glucose, which is determined through insulin sensitivity. These 2 components would equal to bolus insulin for that meal. So how did we do this? When we first started in 2013, we needed to have a team, and we continue to have a team. And our team consists of patients and their family, physicians, nurses, and dietitians. We do have a separate carbohydrate counting clinic to focus on carb counting and insulin adjustment only. And we find that we take about 4 to 6 visits to complete the carbohydrate counting class, walking someone from not knowing how to count carbs to flexible insulin dosing. So the first visit is really a teaching session, and we use multiple medias and teaching tools. For example, the picture on the left here is a dietitian who was teaching these patients about carb counting using the slides, which is not shown in here, but she talked through the slides in introducing them to carbs, etc. And then we also have food models. And I know these are not exciting to have plastic food, but we do have real food because rice is a stable food. In Thailand, we really want to make sure that they can measure the rice correctly. So we have them scoop the rice and they can tell how much is really 1 carb or 15 grams. So they practice that here. And we also give them a book, which we produce to be for the carb counting using Thai food only. And I think this is important to have your local food menu so that it would be what they're eating. These are examples of our pictures in the slides that we use. We teach them the amount of rice for 1 carb, of 15 grams, 1 piece of bread, half an ear of corn, 1 small apple, milk, etc. We also teach them how to read labels. And reading labels sometimes can be confusing. So we go over how many serving size are they in container. So the each information in the label is applicable to 1 serving size. In this case, 18 crackers. They will scroll down to the total carbohydrates, and that would be number of grams. We do pre-test and post-test, and this is in Thai just to kind of check their knowledge and make sure that they have learned the carb counting concepts. And then we give them homework and to do the food record. And I know food record is boring, but it is essential for us to help them count the carbs accurately. And at the beginning, we ask them to log everything that they eat. This whole sheet is 1 day, and it has 6 boxes: breakfast, lunch, dinner, snack, 3 times. And what exactly we ask them to do is to pretend that they're a chef and analyzing everything that they eat. For example, this is a box for breakfast. They would put in the glucose level in the morning, the insulin that they take, and pretend that, again, they're a chef. For example, this person ate pad thai. What is in pad thai? Noodle, bean sprout, egg, peanuts, sauce. Separate them out, put in the amount, and log in the amount of carb for each component. For example, noodle has 45 grams, bean sprout, eggs, and peanuts don't have any, and any hidden sugar in this case, sauce has 10 grams, so they would tally it up. Beverages do the same thing, and then total up. For example, this meal has 96 grams. Like I said, they can also count in portions or exchange and count down to 1/3 of a portion, which is 5 grams of carbohydrates. It is a good opportunity to review the insulin injection techniques, and you'll be surprised how many people have been taught so long ago and no one has reviewed them and they are not doing it correctly. We also review hypoglycemia and how to treat, and ketone testing if needed. I do have some tips and to-do list for visit 1. For a physician, we review the history to see if they have type 1 or type 2. And most of our patients are type 1, but we do have some type 2 who come to attend the carb counting class who are on multiple daily insulin injection. We stress that we do not change their food. It's not the time to ask them to eat healthy. It's the time to ask them to count the carbs of the food that they eat. And naturally, some people do eat less anyway when they have to put in everything on the food record. For type 1 diabetes on basal bolus, I only ask them one thing. So please eat only the main meals unless they have hypoglycemia, because this could facilitate us in determining insulin to carb ratio and insulin sensitivity factor. Because in general, people do not, even though they should, many people forego insulin injection with the snacks. I mean, if they're already doing it, great, but that's not a common thing that I have encountered. And again, to declare that this talk is mostly applicable for people on self-monitoring blood glucose using finger sticks and insulin injections. The insulin pumps and glucose sensors are not included in this talk, although even though people are on the pumps or sensor, carbohydrate counting is still a cornerstone of managing their diabetes. We review their glucose levels and we don't adjust insulin unless it were obvious hypo or hypoglycemia, just let them go. Keep in mind, in type 1 diabetes, total daily dose 0.5 to 0.7. If they're using more than 1 unit per kilograms, you look for the reason why. It could be during adolescence, they have more insulin resistant. They could be non-compliant, or they could have incomplete insulin dose, meaning that they inject, but they didn't get the full dose. And that come from either they have injection site leakage of insulin when the technique is not correct, insulin storage, or they have a lipohypertrophy at the injection site. Do ask about the snacks. Again, we tell them, because many patients don't understand the insulin action for the rapid acting insulin analog. Tell them that insulin is only for the meal in front of them, not for the snacks that they have eaten 3 hours ago or what they plan to eat in the next 3 hours. we give out the patients measuring cups to practice at home. These are cheap to buy. It's helpful. We ask them to go home and practice measuring the food that they like to eat, especially when they eat out. Could be rice, noodle, peas, etc. To know the portions of what is one carb, so that when they eat out, they don't have to bring the measuring cups with them, and they can use the best estimate to count the carbs when eat out. We ask them to count all hidden sugars and sum them up before rounding the numbers. It's all in sauce and crust, etc. that we say before. So we let them go home, keep all the logs, come back relatively soon. People can't keep logs for months and months, so maybe a week or two to come back. So visit 2 and 3 is focusing on counting the carb correctly. So it starts off by them meeting with the dietitians to go over their homework and interviewing them how much they eat, determining whether or not the carb counting is correct. We also institute the concept of count. Check the blood sugars, count the carbs, inject the insulin, and then eat. So it's a full concept. Check, count, inject, and eat. And next step is to really, like I said, determine that they're counting the carb correctly. So like I said before, errors can happen. Generally, 5 grams of carbs equals to free food. Therefore, again, we ask the patient to count out the 5 grams or 0.3 carbs. Occasional errors can occur up to 0.5 or 1 carbs. That might be acceptable. Other tips to do for visit 2 and 3. This is time to practice with the help of dietitians. In general, people consume about 30 to 75 grams of carb per meal, or between 2 to 5. At this time, physicians can start calculating the insulin to carb ratio and insulin sensitivity using the numbers that we have learned before, but don't apply it yet. But you can practice checking from the food log and to see if this ratio actually might work in that individual patient. For example, for insulin to carb ratio, you can pick a pair of good blood sugars and check from total daily dose. For example, this person takes 40 units of insulin in one day. The insulin to carb ratio should be about 11. And he gives you 3 sets of blood sugar along with the carb. In this case, he counts in a portion and the number of units of insulin that he takes. So this first pair is actually pretty good because the glucose excursion free and the next meal is only about 17 or so milligrams per deciliter. He took in for carbs, which is 60 grams to 6 units. So that's about 1 to 10 and resulting in good blood sugar number. So your ICR might be close. Looking at the next pair, he ate this time a little bit more, still injecting the 6 units because that's what people end up with, doing fixed dose of insulin, but they don't eat the same food each meal. So he ate 5 carbs more than breakfast, still injected 6 units, and that results in a higher glucose at dinner. So then, therefore, you can tell that 75 grams for 6 units, that insulin is not enough. So maybe the ratio of 1 to 10 or 1 to 11 would work in this person. And sometimes you may have some odd readings. For example, in the same person reporting only eating 1 carb at lunch and injecting 6 units. So and resulting actually in a high glucose number at dinner. So in this case, you should suspect that they might have had inaccurate carb counting, especially under count, or they had hypoglycemia in between meals and they didn't tell you. And please be aware that insulin to carb ratio higher than 1.5, meaning 1.4, 1.3, 1.2 may signal some errors, especially in non-obese patients. At this time, physician can start adjusting basal insulin if it's obvious that they need more. And if ready, you can start with insulin sensitivity or correction. So the tip to do insulin sensitivity is to think about how insulin sensitive the patients are and at which glucose level would you like to start a correction. For example, if this person has a total daily dose of 25 units, ISF is 70, meaning that 1 unit of insulin lowers the glucose by 70 milligrams per deciliter, you might want to start correcting at the blood sugar of 200 because 1 unit would lower to 130 instead of starting at 140, in which 1 unit would lower the insulin to 70 milligrams per deciliter, which is too low. And again, in patients with high insulin requirement, inaccurate carb counting will result into larger errors of insulin dosing. We also use a lot of telehealth support, and I think this, has becoming more and more popular. So the patient can actually send us pictures of the food they eat, and we give them feedback in real time instead of using the food log all the time. And you can see that this person follow the lesson. You scoop up the rice in 4 little 1/3 of a cups here. So it's got 4 mounds here, which is equivalent to 4 carbs. And he put in what he was counting here. I realize they're all in Thai, but what he was saying here is that these are 4 carbs, the fried eggs do not count. The curries also do not count, but he does have a little bit of small orange and a few crackers. So total is 5 carbs. And he gets the feedback right away, and that's helpful in enhancing the patient's confidence. So visit 4 to 6, this is when we walk people to flexible insulin dosing, and there are 2 steps. And the step 1, we ask people to eat fixed carb per meal, meaning that help them choose from the food log that they have put in by now, several weeks, and determine the carb content for breakfast, lunch, and dinner. For example, they might want to say they want to eat 3 carbs for breakfast or for lunch or for dinner. And then they can do mix and match in any combination as long as stay within that content. They don't have to do this for long, but it would help you to determine whether or not the insulin to carb ratio and sensitivity factor that you give them are correct. Then you would assign a fixed insulin dose using the insulin to carb ratio that you calculated, but don't give it to the patients yet, and adding the insulin sensitivity factor. And be mindful that the insulin to carb ratio may be different during different times of the day. And generally, people might need more for breakfast and less for dinner. And when the patients come back for follow-up, double check if the ratios that you give them are correct, meaning that their blood sugars are relatively stable all day. Step 2 is to start through flexible insulin dosing. If the patients do not count in grams, so you please assign them a constant for the patient to use. For example, if they use 1 to 15, 1 unit per 15 grams, but they count in portion, so it would be 1 unit per 1 carb. So this one here is a constant. If they use 1 to 12, they would use 1.25 units per 1 carb. So whatever carb they eat, they would multiply by 1.25, etc. So ask them to calculate using this constant and route the number at the finish at the end. For example, if they use 1.25 units per carb, they eat 3.3 carbs, they multiply the 2 number equals to 4.125. They would round to 4, which is the number that they can give with the insulin pen. We give them this little sheet, a personalized sheet. They can go home with a sheet, they can take a picture of it, but it's the way how we determine the mealtime insulin. First, we check your glucose level before meal, count the carbohydrate contents, and calculate the insulin dose. We give them a little easier laid out. For 1 carb of 15 grams, use however many units, 2, 3, 4, etc. And you can also give them the constant, like I said before, and plus the correction. So this correction, we also have like a negative correction, meaning that it would take out insulin. If the blood sugar generally say between 70 to 90, they would deduct the insulin that is equivalent to what is needed for 1 carb for them, or 15 grams. So they would be able to eat 15 more grams. To correct for relatively low blood sugar, but not through hypoglycemia, if their blood sugar is less than 70, they need to correct before they inject. And then, add the sliding scale for higher blood sugars. We practice with them before they go home. For example, Mr. Alex, if your blood sugar is 200 and you're going to eat 60 grams of carbs, how many units of insulin would you inject? So give them practice like that 3 or 4 times until you are somewhat confident they can do it, they can go home. As far as snacks, they can eat snack. I generally ask them to do this after we have used insulin to carb ratio, sensitivity factor, and glucose values are stable. Because most of our patients don't use the pump or the sensor, it is a little bit difficult for them to determine insulin on board, meaning that if they check the blood sugars relatively close to the insulin they've injected before, because they're going to eat a snack and they correct for that blood sugars as well, it will result in a stacking of insulin and hypoglycemia afterwards. So in general, we said they don't need to check glucose before snacks unless they're feeling hypoglycemic, but they should inject the insulin that is equivalent to the insulin to carb ratio from the nearest meal. And with the 6 and beyond, we continue to have them come back and review accuracy of carb counting, insulin sensitivity factor, and correction during the follow-up. The glucose log becomes a little bit more consolidated. So this is a whole 24 hours of one day, and they can put the glucose carb now in portions or grams and insulin they use, and you can use that to determine whether or not they're doing well. And for example, this person has this sheet with him that is, he used glycine 24 in the morning, insulin carb is 1.7, 1 to 7.5 grams at breakfast, 1 to 10 at lunch, 1 to 15 at dinner. Correction at 1 to 50, starting at 160. So he has this card that he made for himself, how much he would take for each breakfast, lunch, and dinner at varying number of carbs plus the sensitivity. So it's helpful to have that. It allows you to be personalized, and the patient feels like they can have more control of their diabetes. So other tips, carbohydrate counting is only one aspect of type 1 diabetes care. High fat and high protein meal may require more insulin, as we know. Glycemic index can affect the rise and the fall of glucose levels. You should teach patients about good carbs and high fiber meal, which would help with reducing rapid glucose excursion after meal. We can have patients eat out. They need to have quality of life, but when they eat out and they eat a buffet, especially when the meal time is relatively long, they may have to do more than one insulin injections. Again, this is if they're not on the pump. So they eat a buffet, I ask them to go gather the food, eat it in one time, inject, and then maybe go another time and then inject again for the second plate. This is our success story, and we collected this information early on, actually several years already, of the people who had gone through our clinic, showing their baseline hemoglobin A1C between 0 and 3 months, 6 months, 9 months, and 12 months. The baseline is in green and the follow-up is in gray. So the delta hemoglobin A1C reduction is about 0.5 to 0.55%, which is equivalent to what I showed you earlier in the literature. So it does work. And more importantly, we did a survey asking patients how they felt. We did not objectively measure hypoglycemia, but they reported to us that they felt like they had less hypoglycemia, less severe hypoglycemia event. They feel that their glucose control was better. And more importantly, they felt that they had more freedom in eating and they have less concern about managing their diabetes. We did publish this in our local journal in Thailand. It's only a local experience, but I feel that it's important to share what we've learned using our local resources and within our environment. And I'd like to thank our team. We have endocrinologists, dietitians, nurses, endocrine fellows, and our administrative person. And I thank you for your attention, and I wish you the very best for your carb counting program. Thank you for your attention.